I'm sorry. Can you guys hear me now? If you can tell, please. Hello? Am I audible? Okay, thank you. So, should I start again? Now, coming towards the history of presenting illness, I'm going to start again. I'm so sorry that it happened. So, I'll start the history again. It's patient's profile. So, I'm going to be presenting the history as it is expected in the exams, in the final year, third year to final year exams, ward rounds, rotations, etc. So, my patient Ali, 22-year-old male student, resident of Charsadda, presented to emergency department on 22nd of June 2025 at 8 p.m. in the emergency department with the chief complaints of lower abdominal pain, nausea, and fever since one day. So I explained it in fluency, and it's from one day. You always write it in the chronological order, starting from the more days to the lesser ones. For example, if he had pain abdomen since 2 days, nausea and vomiting since one day, so you're gonna write pain abdomen since 2 days, nausea, vomiting since one day. But here he had all the symptoms since one day, so we are gonna continue with that. Then comes the history of presenting illness. If my patient had already, like he had hypertension, asthma, etc., you are going to start the history of presenting illness with my patient is a known case of hypertension and he was in his usual state of health, but he does not have any comorbids. So I'm going to start with it that my patient was in his usual state of health one day ago when he started suffering from pain abdomen that started around the umbilicus and after 6 to 8 hours it migrated towards the right iliac fossa. It was sudden in onset, colicky in character, not radiating to elsewhere, associated with nausea and fever that exacerbated by sitting, standing, and coughing, and relieved while lying down, and was severe with a score of 8 by 10. Whenever you present a history of presenting illness for pain, there is a rule Socrates mnemonic followed. So Socrates, S is for site, O is for onset, C is for character, R is for radiation, A is for association, T for time, E for exacerbation, and S for severity. Then comes nausea. So the second symptom was nausea. Nausea started along with abdominal pain and was in and anorexia, and it has been increasing since then, and it was not associated with vomiting. Fever was low grade, documented to be 99 degrees Fahrenheit. That started with abdominal pain, was continuous in nature, and did not lower to the basal temperature. It was not associated with rigors, chills, or sweating. Upon systemic inquiry, patient did not have any bowel or bladder complaints and no other symptoms were present. So the specific thing about systemic inquiry is that you ask the patient every question starting from head to toe so that you do not miss anything. For example, if it would have been another case and I would have asked my patient the question, so I would have started it like this that a systemic inquiry like do you have headache, do you have blurring of vision, do you have pharyngitis or any breathing difficulties, do you have pain, do you have muscular pain, do you have chest pain, any abdominal issue, any bowel issue, any bladder issue, do you have pain in the limbs, do you have any issue with the limbs. So just like that you ask each and everything and whatever is positive you write it down and the other you write it not significant enough. Coming towards the past history, it is a surgical history. So first we're gonna tell about the past surgical history, then the past medical history, and then the drug history. So it was negative. He did not have any positive past medical, surgical, or drug history. So you are going to say that the past surgical, medical, and drug history of this patient was insignificant. And then comes allergic history and blood transfusion. You're gonna present it like this that he did not have any allergies and he did not have any blood transfusions till date. Coming towards the family history, negative family history for diabetes, hypertension, asthma, ischemic heart disease, CVA, and similar episodes like the above mentioned case. Now, personal history. So, personal history includes all the personal questions, just like the appetite, the bowel and bladder habits, the sleep and the time, and he has no history of drug, alcohol, and cigarette use, and he drinks filtered water. water, you're going to present it like this: that patient had anorexia and his appetite is decreased, normal bowel and bladder habits, normal sleep up to 8 hours. He had no history of any drugs, alcohol, cigarette use, and he drinks filtered water. Then the last heading is socioeconomic history, and my patient belongs to a family of four with one bread earner. He lives in cemented, well ventilated house with two bedrooms. There are no pets in the house. He's socioeconomically stable. And after this, I'm going to tell you about the examination that we did in this patient. So patient is ill looking and prefers to lie still in the bed. He is lying in the bed, well oriented, with no obvious signs of distress. Then vitals, his temperature is 98 degrees Fahrenheit, pulse is 98 beats per minute, BP is 120 by 80 millimeters of mercury, and respiratory rate is 18 beats per minute, breaths per minute. There is no pallor, icterus, cyanosis, clubbing, or lymphadenopathy at the time of examination. On per-abdominal examination, you start with inspection. On inspection, abdomen moves less on right side with respiration. On palpation, localized tenderness in the right iliac fossa is present, maximum tenderness at the McBurney's point, and guarding is present, and rebound tenderness is present. Special signs like Roswing, sauce, and obturator signs are also to be considered in acute appendicitis, and they are important when to know where the site of the appendix is present. So they are positive in this patient. Percussion, there is no shifting dullness present, and then bowel sounds are slightly reduced on auscultation. Other systemic examination is unremarkable. CVS respiratory CNS examinations are unremarkable. Our provisional diagnosis is acute appendicitis, and the differential diagnosis may include mesenteric lymphadenitis, acute gastroenteritis, Meckel's diverticulitis, right ureteric colic, and in females, if this patient would have been a female, we would have considered the ectopic pregnancy and ovarian torsion. That is very important. And whenever you take a surgical history and this is a female, you also take the obstetric and gynecological history as well. You ask for the last menstrual period, and you ask whether the cycle is regular, not regular, and stuff like that. So investigations to be done for confirming the diagnosis are the laboratory investigations, that is complete blood count, that includes the increased WBC count with neutrophilia. Neutrophilia is that because it is mainly bacterial infection, so neutrophils are raised, and CRP is raised, that is an inflammatory marker. Imaging includes ultrasound abdomen, and it states that it is a non-compressible blind ending tubular structure with the diameter of greater than 6 millimeters, and CT scan abdomen, if indicated, is a confirmatory test. Now coming towards the management. So management. Initially, make the patient nil per oral, and we give the IV fluids, we give analgesia, and we give IV antibiotics. And the definitive treatment is appendectomy, either open and laparoscopic. And the complications, if left untreated, are appendicular perforation, appendicular abscess, peritonitis, and sepsis. So, if we give a one-line summary regarding this, a young patient with migratory right iliac fossa pain, fever, localized tenderness is suggestive of acute appendicitis. So, whenever you have a case of acute appendicitis, this is how you present the history and examination, and it is very important as well. If you have any questions, so you can ask as well. And I'm going to tell you about some important points regarding this. So, Alvarado score, that is the clinical scoring method to identify whether it is acute appendicitis or not, or whether you want to get it treated or get it under surgery or not. So Alvarado score includes the mnemonic mantras. M is for migratory pain, that has one score. Then anorexia, that has one score. Then nausea or vomiting, that has one score. Then comes tenderness in right iliac fossa, that has two score. Then rebound tenderness R for one score. E is for elevated temperature, that has 1 score. Then leukocytosis, L has 2 score, and then the last is shift of left side to the leukocytosis, and that is 1 score. The total score is 10. So whenever you add up the score after examination and investigations, uh, if the score becomes 5 to 6, then there is a possibility that the patient has acute appendicitis. If it is 7 to 8, then it is probable that the patient has acute appendicitis, and if it is greater than 9, then it is most probable the patient has acute appendicitis. So this was all about history and examination of the most common and most important case of surgical emergencies. And I'm going to make more videos regarding the history and examinations as well. And if you guys have any queries and you want me to make some videos, you can please comment in the comment section below. If you have any queries right now, you can ask as well. So if this video and presentation was helpful, please like, share and subscribe to my channel. So and please comment if you want OSCE stations, MCQs, Viva questions or surgical Viva questions regarding acute appendicitis or any other topic you want me to make video for. And this is Dr. Asma, and I'm signing off. Keep learning and keep saving lives. Thank you so much. And now I'm going to wait for your questions. If you have any, please do ask questions, please. Okay, so hello Tarot Tales and Double Delight 27. Hi. Do you have any questions? Okay, guys, if you want to learn about separate topics other than the clinical examination and all, I can do that for you as well. I'm going to make a series of different topics, especially the surgical one, as I'm a surgical PGR. So I'm going to make that as well. Okay, thank you, Lyrics Planet.1. Do you want me? Do you have any suggestions that what should I make for you, or either I'm gonna continue making the different topics. I have a 30 days of plan right now that I'm going to cover all the surgical common surgical topics, and then I'm gonna continue making the history presentation and basically case-based learning. But if you want it on the other side, then you can tell me as well. Okay, great. I'm gonna make it. Any other questions, please? Hi, Aura3318. Do you have any suggestions? Oh, thank you. I have a lot of videos regarding the surgical techniques as well. I can upload them as well if you guys are interested. I can make the video step by step and then tell the step-wise procedure as well. Thank you, Zulkarnain 704. Oh yes, I am a doctor. Okay, I can narrate some important points. Uh, First is, yes, Ali Khan, I am a doctor. Okay, so the most important things of today's lecture was that how to present, like we are taught how to take a history, we take it point by point, but we never know how to present it. Whenever we are going to present it, we're gonna make it like, like we don't know how to present, na? So the proper way of presenting it, the proper way of taking a history. Some important points are that you start with patient's profile, taking the name, age, the occupation, then the residency of that patient, particular whether the patient came via the ER or the OPD, and then you come across that the patient came on which date, time, and then which chief complaints were presentable. उर्दू, ओके। सबसे पहले जी आपने बताना है कि पेशेंट आपके पास आया है, इमरजेंसी के ज़रिए आया है या ओपीडी के ज़रिए आया है, किस तारीख को आया है, पेशेंट का नाम क्या है, और पेशेंट जो है वो क्या करता है, उसका काम क्या है, कहाँ का रहने वाला है और किस तकलीफ़ के साथ आया है। पेशेंट जब आएगा उसमें क्या तकलीफ़ है उसको, आइदर उसके पेट में दर्द हो रहा है, जैसे हमारा ये मरीज़ है, इसमें ये बताया गया है कि पेट में दर्द था उसके और उसको उल्टी आ रही थी और उसको बुखार था साथ में। बाकी इसके बाद है हिस्ट्री ऑफ प्रेजेंटिंग इलनेस। इसमें आपने मरीज़ का बताना है कि मरीज़ को जो है ना, पहले से अगर कोई तकलीफ़ है तो वो आप इस तरह बता देते हैं कि दैट माई पेशेंट इज़ अ नोन केस ऑफ वट एवर। लेकिन अगर नहीं है, जैसे हमारे इस मरीज़ को कोई प्रॉब्लम नहीं है, मैंने नीट नहीं दिया था, नम्स दिया था बेसिकली, एंड मेरी स्पेशलिटी आई एम इन प्लास्टिक सर्जरी। आई एम PGR2 राइट नाउ। ओके, सो मैं ये बता रही थी इसमें कि आपने पूछना है मरीज़ को, जैसे दर्द अगर है, पेन एब्डोमेन के लिए आप सॉकेट्स फॉलो करते हो, दैट इज़ साइट, ऑनसेट, कैरेक्टर, रेडिएशन, देन एसोसिएशन, टाइम, एग्जर्बेशन एंड सेवेरिटी। साइट मतलब कि कहाँ दर्द है, ऑनसेट कब से है, कैरेक्टर किस तरह का दर्द है, आइदर इट इज़ कॉलिकी, थ्रॉबिंग, शार्प या पेनिट्रेटिंग या इस तरह की इंजरी, मतलब इस तरह की पेन है। देन एसोसिएशन किस चीज़ के साथ एसोसिएटेड है, या तो उससे उल्टी हो रही होगी साथ में, या बुखार हो रहा होगा, या पेट में दर्द है, या उसका दिल ख़राब हो रहा होगा। फिर टाइम मतलब कितने दिनों से दर्द है, कब से दर्द है, पहले कहाँ दर्द था, अब कहाँ दर्द है, ठीक है। पार्ट 1 का स्कोर नहीं होता, इट्स जस्ट पास एंड फेल। जब रिजल्ट आता है तो उसमें से कितना होता है कि यू हैव पास्ड और नॉट। अगर आप फेल कर दो तो फिर स्कोर पता चलता है। ओके, सो एंड एस इज फॉर सिवेरिटी। सिवेरिटी हमेशा आप स्कोरिंग पे पूछते हो मरीज से कि आप बताएं कि आपको कितना दर्द है। 0 मतलब कि बिल्कुल दर्द नहीं है, और 10 मतलब ऐसा दर्द जो काबिल बर्दाश्त ना हो। एंड देन अगला हमारे पास है पास्ट हिस्ट्री। पास्ट हिस्ट्री में आप पूछते हो पास्ट सर्जिकल, पास्ट मेडिकल। पास्ट सर्जिकल हिस्ट्री में आप पूछते हैं कि आपका इससे पहले कोई ऑपरेशन तो नहीं हुआ, अगर हुआ है तो किस चीज़ का हुआ है, कितना अर्सा पहले हुआ है, और क्या आप उसके बाद ठीक हो गए थे, और अस्पताल में आप कितने दिन रहे थे। दूसरा, पास्ट मेडिकल हिस्ट्री में भी आप इसी तरह पूछते हो कि क्या आप इससे पहले कभी किसी मर्ज की वजह से अस्पताल में दाखिल हुए हैं, अगर हुए हैं, आपको कोई मर्ज है, आप उसके लिए कोई दवाई वगैरह ले रहे हैं, या आप बिल्कुल ठीक होकर यहाँ से गए थे। तीसरा है ड्रग हिस्ट्री। ड्रग हिस्ट्री में आप पूछ लेते हैं कि पेशेंट ऑलरेडी कोई मेडिसिन तो नहीं ले रहा है। जैसे फॉर एग्जांपल काफ़ी पेशेंट्स होते हैं जो एपिलेप्टिक होते हैं, वो फिर मेडिकेशंस पे होते हैं, उनसे आपने पूछना लाजमी है। कोई ब्लड प्रेशर की दवाई ले रहा है, कोई शुगर की दवाई ले रहा है, उन दवाइयों के नाम और ये सब लेना ज़रूरी है। फॉर एग्जाम्पल अगर सर्जिकल केस हो तो उसमें बहुत ज़रूरी होता है कि आप पूछो कि पेशेंट कहीं ब्लड थिनर्स वगैरह पर नहीं है, क्योंकि अगर इमरजेंसी सर्जरी करनी पड़ती है या अगर इलेक्टिव प्रोसीजर्स भी हैं और पेशेंट ब्लड थिनर्स पे है, तो आपको एटलीस्ट फॉर एग्जाम्पल अगर हम लॉपरिन ले लें तो उस पर हम ये है कि हमें एक हफ्ता पहले एटलीस्ट वो ड्रग रोकनी पड़ती है, ताकि हमारी जो है ना वो पेशेंट को कोई एडवर्स इफेक्ट ना हो उसके लिए ना, क्योंकि ब्लीडिंग स्टॉप नहीं होती बिकॉज इट हैज़ एन एंटीप्लेटलेट इफेक्ट। उसके बाद हमारे पास फैमिली हिस्ट्री आ जाती है। फैमिली हिस्ट्री में ना हमने पूछना है कि ये जो कॉमन होती हैं डिजीजेज जैसे डायबिटीज़, हाइपरटेंशन, अस्थमा और ये सब, ये कहीं उसकी फैमिली में रन तो नहीं कर रहे। पर्सनल हिस्ट्री में आप पूछते हैं पेशेंट को उसकी पर्सनल हैबिट्स के बारे में, ऑक्यूपेशन के बारे में, वो पानी कहाँ से पीता है और उसकी बाउल एंड ब्लडर हैबिट्स कैसी हैं। देन कम सोशो इकोनॉमिक। सोशो इकोनॉमिक हिस्ट्री में यू आस्क फॉर कि पेशेंट कहाँ मतलब कैसी फैमिली से बिलोंग करता है, और ये सब चीज़ें आप डिटर्मिन कैसे करते हो। पेशेंट ये तो नहीं बताएगा मैं अमीर हूँ कि मैं गरीब हूँ, वो इस तरह बताता है कि आपने ये पूछना है कि एक तो पेशेंट के कितने फैमिली मेम्बर्स है। मैंने कौन सी बुक से पार्ट 1, मैंने पार्ट 1 की तैयारी जो है ना, एक तो वो USMLE की बुक है फर्स्ट एड उससे, एंड सेकेंडली मैंने की है प्रेपरेशन रफ़ीला से और साथ में SK सीरीज से, एंड ऑब्वियसली ये हमारी जो बेलियन लव और बाकी पैथोमा और ये सब लाइक थोड़ा थोड़ा करके हर एक से रिपीट किया था। बट अगर आप USMLE वाली बुक और वो सब कर लेते हो, रफ़ीउल्लाह भी अच्छे से पढ़ लेते हो, SK सीरीज़ को एक दफ़ा रिपीट कर लो तो एक अच्छा चांस बन जाता है आपके लिए। पास्ट पेपर्स आर वेरी इंपॉर्टेंट, लेकिन कॉन्सेप्ट्स आर ऑल्सो इम्पॉर्टेंट बिकॉज अब मैंने सुना है कि थोड़ा चेंज हुआ है पैटर्न पेपर्स का। अच्छा, सो अल्वाराडो स्कोर का मैंने बताया था इसमें, और अल्वाराडो स्कोर इज़ माइग्रेटरी मैंटल्स इसका निमोनिक है। M फॉर माइग्रेटरी पेन, जैसे हमने देखा था कि हमारे पेशेंट को अराउंड द अम्बिलिकस पेन स्टार्ट हुआ और 6 से 8 घंटे बाद वो दर्द सीधी साइड पे पेट में चला गया, दैट इज़ राइट इलियक फॉसा। सो स्टार्टिंग एट द अम्बिलिकस, देन आफ्टर 6 to 8 hours it radiated to the migrated to the right iliac fossa and then it settled there. So that is one score, इसका 1 स्कोर होता है। देन एनोरेक्सिया मतलब दिल खराब होना, और इसमें भी 1 स्कोर होता है। देन नोजिया एंड वॉमिटिंग, खुराक का दिल नहीं कर रहा, उसका 1 स्कोर है वॉमिटिंग। देन टेंडरनेस इन RIF 2 स्कोर है इसका। रिबाउंड टेंडरनेस का 1 स्कोर है। एलिवेटेड टेम्परेचर का 1 स्कोर है। ल्यूकोसाइटोसिस का 2 स्कोर है। एंड देन शिफ्ट ऑफ द लेफ्ट ऑफ ल्यूकोसाइट्स इज 1 स्कोर एंड इट इज आउट ऑफ 10। देन वी डिसाइड कि आइदर एक्यूट अपेंडिसाइटिस है कि नहीं है। उसके बाद हमने एग्जामिनेशन जो है ना वो डिस्कस की थी, जनरल फिजिकल, पर एब्डोमिनल एग्जामिनेशन एंड देन दी सिस्टमिक एग्जामिनेशन, एंड देन हम लोगों ने अपनी डिफरेंशियल डायग्नोसिस बनाई, देन DDs, एंड then we went for investigations, the laboratory investigations and the imaging. And this was all the case presentation. And then we discussed the management as well. If you have any questions regarding this, you can ask, please. Anything about acute appendicitis you can ask. And no problem. If there are no more questions and nobody is engaging anymore, so I think I should wrap up the session. So if this session was helpful, kindly guys, please like, share, and subscribe it as well. And I'll do weekly or maybe more than once in a week live session for any queries, and then I'm gonna be uploading videos of case presentations, different topics every day, and I'll try to be consistent. And then if you guys have any comments and any suggestions, then I'll also be uploading that video as well. So thank you so much. I'm signing off. Keep saving lives and keep learning. Allah Hafiz.